Woo! I mean, I thought the average was good.
Those average is good? Okay, awesome. All right, well, welcome to your review for me. Hair test on Friday. I will post these slides after today. I kind of want you can take notes, but I really want you to try to think about these things without having the answer right in front of you. Okay, so you will get this after. All right. So you have a 24-year-old, 6 hours after slicing his forearm on sheet metal. The wound is clean, sharply demarcated without contamination. Your ear gate and plan to close. What is your the best healing method? What's the most appropriate?
Primary.
Good. Primary then. Good. What if it was more than 24 hours old?
Secondary.
Next week. All right. Out of these statements, which regarding suture tensile strength is correct? Who wants A? B? C? D? E? A 6.0 is a smaller diameter than a 2.0.
Yes.
Okay. All right. You have a 68-year-old diabetic patient with a 5-centimeter contaminated lower extremity laceration that was sustained 18 hours ago in the barnyard. After irrigation and debridement, the wound remains questionable. What is the most appropriate closure strategy?
Secondary.
All right, while closing facial laceration, the wound requires, or any laceration for that matter, the wound edges invert despite proper technique. What type of suture technique is most appropriate? So if you're doing interrupteds and the wound edges keeps inverting, which one do you want to then go to evert?
Uninterrupted.
The type of interrupted. What do you think? Any guesses?
There's not 5 answer choices.
There are, yeah. What's that? Close. Vertical mattress. Vertical mattress, okay? Because you're going in the same line, out and then in, so it'll evert a lot better. Okay? Alright. Which needle type is preferred for skin closure?
Reverse cutting.
Reverse cutting or just
like
cutting? Right? Good. Alright. You're closing a long, low tension abdominal incision. You want rapid closure with even tension distribution. The patient may require partial removal of sutures if infection develops. Which technique presents the greatest risk if a single stitch fails?
Uninterrupted.
Greatest risk of it failing?
Running.
Running. Alright. So is this patient, do we want to use a running if we think that they're most likely going to get infected?
No.
No. Okay. So greatest risk of a single stitch failing is running. Okay, you have a 30-year-old patient with a scalp EIC. Lesion is inflamed and tender. What's the best management? Depends.
Drain it.
If it's a sebaceous cyst, maybe you want to IND it. But if it's a rock hard infection type thing looking, maybe you want to delay until that inflammation and infection clears up. Okay.
Yeah.
It really depends on what it looks like. If it's fluctuant, you can throw an ultrasound on it to see if there's actual an abscess underneath it. But if it's a true cyst, you really want that tissue to be not as inflamed and infected. Okay. All right. Monofilament sutures generally require how many knots to secure? Let's say monofilament, non-absorbable.
2,
5.
5.
Right, 3 to 5. When you have the non-absorbable monofilament, think like nylon, right? Like fishing line, you're not going to get a good knot in that, so you may have to do more knots in order for it to actually stick. Alright, during wound closure, you know excess blanching around the wound edges after you're tying your sutures was most likely indicated.
Too tight.
Too tight, which means what? If your sutures are too tight, what is it going to lead to?
Improper.
So I think I heard it, ischemia, and then necrosis. So what do you got to do? Take them out and do it again. Alright, you have a 100 kilogram patient requiring laceration repair without epinephrine. What is the maximum safe dose of lidocaine? Lidocaine without epi. What's the max dose?
100 milligrams.
Say it out loud. I'm deaf, I can't hear you. 300.
300.
Good. What if it's with epi? 500. Okay, what's the mil per kilogram or mg per kilogram?
3.
3 if it's without epi,
epi.
or no, 4.
4.
4.
Okay.
Sorry. 4 without epi. Was it with epi?
5. No, it's 7. What's it 7?
7. Okay, you might see that again. You're removing sutures on a post-op day 7 from a facial wound. After removing, there's mild separation that occurs. What's the next best step? You just gonna leave it open? A clean wound that's just slightly separating? Because you took the sutures out too soon? What do you want to do?
Put your back up.
Steri strips. Yeah, we're not going to put more sutures in. We're going to actually support the wound with some steri strips. You will have this. Okay. All right. Which forceps are appropriate for internal tissue handling? I'll give you a hint. It's either Addison's or DeBakey's. Which one do you want to use?
DeBakey's.
DeBakey's. And you want to use Addison's for skin edges, right? Why?
They are grippy. They have
Grippy.
They have the little biters. Or whatever.
So you have the rat tooth, right? So it doesn't crush tissue versus internal tissue, and we don't want to necessarily crush it either, but it's less likely of a crush versus the edge of the tissue, edge of the skin. Okay, so Addison's with rat tooths on the skin, DeBakey's on the inside. Good. All right, a patient returns 4 days after closure with erythema, purulent discharge, and tenderness at the incision site. What do you want to do? There are a lot of murmurs. Take them out. Then what? Okay, you're going to close by secondary extension. What do you got to do in between? Any antibiotics?
Clean it.
Clean it. Alright? You can't just take the sutures out. You got to take them out, irrigate. Okay, get rid of that abscess that's underneath. If it's big enough, you may need to pack. Okay? Remove all closures, irrigate. When do you want to do antibiotics?
Systematic symptoms?
Nope. So if this patient, right, you take out the sutures, have you gotten source control?
No. Well, yes.
Right? If it's just a little abscess underneath the skin, and you can take care of it by opening up that incision, right? That's source control. When you have cellulitis, when the infection is within the tissue surrounding that abscess, that's when you want antibiotics. Okay? Just opening it up and irrigating it and leaving it to close by secondary tension is not going to be enough. So cellulitis is that trigger. Okay? Not just the abscess. Does that make sense? Okay. While closing and deplaceration, you're concerned about dead space and the formation of seroma. What technique do you want to use? What do you think? Hey, what are those called? Deep dermals. Very good. Right? So subcutaneous, you want to get that deep dermal to help prevent hematomas and seromas. So you got to close that bottom space first, and then you can close the skin. All right. Going back to this one. Say you did the deep dermal. How are you going to close the skin? Many different ways, right? What are your options? Steri-strip, sure. Yeah, sure.
Superficial sutures.
Superficial sutures, like what? All of them are superficial sutures. Interrupted, sure. What else? Mattress, sure. If it's under high tension. What about if you don't want to have the patient come back? Absorbable, and what? There's two different ways that you can do absorbable, right? Huh? Okay, one more time. These are deep dermal. I want the superficial ones. I heard buried. Barium, sure. What's the name? Remember the running subcutaneous stitch? Right, where you go the level of the skin, okay, versus running going through the skin. Okay, you can do either. You can do interrupteds if you don't want to have them come back. Okay. What about Dermabond? Dermabond an option? Absolutely. Yeah. All right. What best distinguishes analgesia versus anesthesia?
Levels of consciousness.
Consciousness has to do with it, but what? What about consciousness?
Anesthesia knocks you out, analgesia just numbs the pain.
Yes. Right? So analgesia just relieves pain, does not knock you out. Okay? Anesthesia, you should have loss of consciousness. Okay. Alright, during IND of an abscess, patient reports severe pain despite adequate lidocaine infiltration. What's most likely cause? Why didn't it work? Infection. Alright, local infection causes that tissue acidosis and it doesn't uptake well. Good. Alright, patient developed urticaria, wheezing, hypertension within 10 minutes of receiving lidocaine. What's the most appropriate immediate treatment? First of all, what'd you do?
Too much?
Too much, or? You may be going anaphylactic, sure. With the wheezing, urticaria, yep, hypertension. Do you think maybe you possibly put that lidocaine in a vessel? Potentially? Alright, what do you want to do for it? What's the treatment? Do you have someone who's going into anaphylactic shock? What do you give them?
Epi.
Epi! Right. Okay, so that's the most appropriate immediate treatment if you have someone who's wheezing, urticaric, hypertension. Okay? Alright, patient receives local anesthetic. They've just developed circumoral numbness, tetanus, and metallic taste. What's the next step? Is this normal? No. You gave too much. What do you want to do? Discontinue. Just stop it. Alright? You can't really take it out, but you can at least stop. Alright, which intravenous induction agent is most likely to cause hypertension due to vasodilation and myocardial depression? I think I heard it. Propofol. Good. Alright, so if you have somebody you're doing conscious sedation on in the ER, right? And they're already hypotensive, do you think you're going to use propofol?
No.
No. What other agents do you have? Ketamine. Absolutely. Love ketamine. Alright, what's the max dose of epi? Or, what's the max dose of lidocaine with epi?
7.
7 what?
Kicks per mig.
Megs per kg or?
500 top.
500 tops. Good. Alright, a patient with spinal anesthesia, becomes nauseated with a heart rate increasing from 70 to 125. What's the most appropriate next intervention? What'd you do? What happened?
Didn't get it properly in the spinal canal.
So you're instilling analgesia or anesthesia in the spinal canal. What happened? Do you think the heart rate is increasing just on its own, or is it a response to something?
Reflux.
It's a reflex. From what? I'm not going to give it to you. What do you think? Why does your heart rate increase significantly, very quickly? What is it trying to do?
Compensating for hypotension.
Compensating for hypotension. All right, so what do you want to give? Pressors, like what? Phenylephrine. Good. All right. Spinal anesthesia is injected into what space? No, not epidural. Something epidural. Subarachnoid. Good job. All right. Postoperative patient under epidural anesthesia has the inability to void. What's the most common cause? What do we do? Do you think that they're not peeing because they can't pee or because they have no pee?
SIEDH.
Probably can't pee, right? From something we did. So what did we do?
Not give enough fluids.
Nope. Remember this? Parasympathetic blockade. Alright, we have an epidural. Most likely going to cause urinary retention because we've blocked that sympathetic tone, that sympathetic pathway. Does that make sense? Okay. Patient under general anesthesia develops muscle rigidity, hypercarbia, tachycardia, and raising temperature. What is the most immediate treatment? First of all, what is it? What am I describing? Malignant hyperthermia, hyperthermia. What do we do? Dantrolene. What else? If they have a high temperature, or is dantrolene the only thing we're going to give?
Antipyrogenics.
We're probably going to ice them, right? Put them on cooling table, okay? All right, capnography directly measures what? What type of CO2?
Expiratory.
End-tidal CO2, expiratory, good. All right, you have a 22-year-old, tall, thin male, smoker, presents with sudden thoracic chest pain and dyspnea. Breath sounds are decreased on the right with hyperresonance to percussion. Use hemodynamically stable. What's the most likely diagnosis? Spontaneous pneumo. All right, what are you going to do for it?
Needle decompression.
He's stable.
Oxygen.
Sure, we could potentially do oxygen, but he's, thoracic chest pain, dyspnea, probably not. He's probably bigger than what supplemental O2 is going to be able to treat. So what do we have to do? Well, we're going to x-ray it. We're going to see it, because more than 30%. Chest tube. Right? When do we do needle decompression? When he becomes unstable, when he's starting to decompensate, right? Okay. Alright, traumatic patient becomes hypotensive with tachycardia, distended neck veins, trigger deviation to the left, and absent breath sounds on the right. What's the immediate next step? Where? Where's it going? Not just side. Okay, I see pointing, a lot of pointing, but what are the words? Second intercostal space, mid-clavicular line, or? Good. Fourth or fifth ICS at the anterior axillary line. Good. Okay. 68-year-old woman with CHF presents with dyspnea, chest x-ray, shows bilateral costophrenic angle blunting. Thoracentesis reveals pleural protein of 2.1. LDH of less than 200, specific gravity of 1.014. What's the type of effusion is this? What are two types? Exudative and transitive.
Transitive.
Which one is it?
Exudative. High protein.
Well, if I didn't say exudative was right, what's
It is transitive.
It's transitive, right? Less than 3. If the protein is less than 3, it is transitive. Okay? What are the some like common cause of transitive?
Infection.
Infection, CHF, non-infection.
Oh, non-infection.
Yeah, sorry, infection, CHF. Well, oh, now you got me confused.
I just took a
All
test. My
right.
brain.
Just remember, if the protein is less than 3, right, it's going to be transitive. You're going to think more CHF. If it's greater than 3, it's going to be exudative and more malignant. Okay, you have a patient with pneumonia, develops fever, pleural chest pain, thoracentesis, reveals thick purulent fluid with high LDH and low glucose. What's the diagnosis? I heard it. What is it? Empyema. Good. High LDH and low glucose. Why is it low glucose?
Bacteria.
Because the bacteria eats the glucose. Okay. All right. What's the gold standard for imaging in evaluating a complex or loculated pleural effusion? CT chest. Is that it? With or without contrast? With. Good. We want to see that rhyme. Okay. All right. A patient with recurrent malignant pleural effusions undergone a chest tube drainage with full lung re-expansion. What's the next best step to prevent reoccurrence? We just gonna leave that tube in? What are we gonna do? The lungs are expanded. What are we gonna do? How are we going? Okay, forget the rest of the question. How do we prevent reoccurring pneumothoraces or reoccurring pleural effusions? How do we prevent them? We can't really. Okay, how? It's part of surgery. You have to do surgery to do it. Pleurodesis. Pleurodesis. Good. What are you going to use? Or what are the things we have available to us? Talc. Doxy. What's the last one? Mechanical with our Burrow pad, right? So we want to scar that surface so that lung sticks up and prevents reoccurrence of fluid reaccumulation. All right. Any questions on the first 3? So like any questions on minor procedures, anesthesia, and thoracic? Okay, let's move on to hernias. What is it, or an indirect inguinal hernia originates where? I may have to do something real quick. Hold on. My slides got screwed up. Oh. Alright, I added slides. Apparently. So into the internal ring, good. Where in regards to the epigastric muscles? Lateral, good. Okay. Apparently when I redid my slides, there's some more thoracic. All right, a 4-year-old patient presents with cough, fluid, or fever, putrid sputum, and further chest pain. Chest X-ray shows thick walled cavity that contains fluid. Was most likely diagnosis? What do you think? What are your 2 primary diagnoses? Abscess, lung abscess, right? Could this also be an empyema? Maybe. But this one is lung abscess. Okay, what's the most common type of lung cancer? Non-small cell, which includes which three types? Adenocarcinoma. Two more. Squamous cell carcinoma. And if it's not non-small, it's what? Large cell. Good. Okay. Good. All right, 78-year-old female presents to the ED with ipsilateral shoulder and arm pain, cough, chest wall pain, ipsilateral mitosis, pitosis, and anhidrosis. What's the most likely primary diagnosis? Pancoast tumors. What will you likely see on your chest x-ray?
HSC? Tumor in the apex.
Yeah, tumor in the apex, right? What's the most likely if you have a Pancoast tumor, what's the most likely type of tissue? First, is it non-small cell or small cell? Non-small cell. And then out of those three that we just talked about, what's the most likely cause of a Pancoast?
Squamous cell
Okay.
carcinoma.
Causing Horner's and Pancoast syndrome, and then that's superior sulcus mass at the apex. Okay. All right, you have a patient with a cough, hemoptysis, and chronic atelectasis. Where do you suspect the lung tumor to be located? Where do we find them? Are they peripheral? Where else do we find lung tumors? Did I hear it? Hilar or centrally? Okay, which one do you think this one is?
Tyler?
Hilar, centrally. Okay? Next to the hilum, touching and compressing the bronchus. Alright. You have a patient with a diagnosis of small cell lung cancer. Which substances do you need to be monitoring for? Small cell is notorious for causing what type of syndromes? You remember? ADH? Absolutely. Absolutely ADH. What are the things that ADH can do? Affects the sodium how? Low sodium with SIADH, right? What about MSH production, right? The hyperpigmentation, and then ACTH production. So if you have someone who's got a diagnosis of small cell, you should be looking at ADH-like substances, okay? All right. You have a patient who is found to have a lung nodule on a recent x-ray. They would like to discuss potential for it to be malignant or not. What characteristics do you discuss that increase their chances it is malignant?
Smoking.
Get back to that one slide. Greater than 2 centimeters, good. Irregular? What's that? Increasing in size? Yep. Multiple locations and speculated border. Good. All right, you have a now we're back into groin. 26-year-old male presents with a right groin bulge that increases with Valsalva. On exam, the bulge is felt at the tip of your finger. During the scrotal invagination exam, what type of hernia is most likely? Think back to the cannoli. Okay, you put your finger up through the cannoli. You can feel it at your tip versus your knuckle. Which one is it? Indirect. Good. If it's going through the side of the wall of the cannoli, or the inguinal ring, or inguinal canal, it's going to be direct. Good. Sure. All right. 72-year-old woman presents with nausea, vomiting, and crampy abdominal pain. She has a small, tender bulge inferior to the inguinal canal, or inguinal ligament medial to the femoral vein. What's the most likely diagnosis? more what? Hernia. Is this strangulated, incarcerated, or reducible? What do you think? If she's already having nausea, vomiting, and crampy abdominal pain, it's at least incarcerated. What makes it strangulated? Fever, leukocytosis, erythema over the bulge. Good. All right. Which groin hernia carries the highest risk of incarceration and strangulation? What are your three groin hernias? Direct, indirect, femoral. So which one is most likely to be incarcerated and strangulated? No.
Femoral?
No.
Femoral?
Femoral. Good. Alright, a patient with a non-reducible groin mass has leukocytosis and fever. The underlying skin is erythematous. What complications most likely occurring? Come on, I just incarceration. Huh?
Incarceration? Or not strangulation?
Strangulated, right? They have leukocytosis, they have fever, and the skin is red over top of it. It is inflamed. Okay? It is strangulated. Alright, a 2-year-old child has persistent umbilical hernia. What's the most recommended management?
Surge.
What if they're 1? And it's reducible.
Just observe.
Sure, right? At 2 is when we start thinking about surgical repair if it's persistent. Alright, patient has a midline bulge. When raising their head from supine, no discrete fascial defect is palpated. What's the diagnosis? What's the 2 hernias you should be thinking of? Diastasis recti, which is not technically a hernia. And what's the other one? Mimics it? The same area? Above the umbilicus? Huh? What is an epigastric hernia subtype of? Think ventral hernias. Right? Ventral hernias, you will feel a distinct defect. Versus a diastasis recti, you will not. Okay? Do we surgically treat diastasis recti?
No.
Not initially, right? We do physical therapy. See if we can close down with four workouts. Is a ventral hernia ever going to get better with a core workout?
No.
No. All right. Initial imaging modality for suspected inguinal hernias when diagnosis is uncertain is?
Ultrasound?
What do we do first? Ultrasound. Right. Right? Brain ultrasound. Then what do we do if we still can't figure it out? CT. CT what?
With contrast.
CT, abdomen, pelvis, with contrast.
Contrast.
Good. Alright. Any questions on hernias?
All of them.
No? Okay. Alright. Which is the most common histological type of breast carcinomas? Ductal. Good. What's your other type? Ovular. Good. A 24-year-old woman presents with a 2-centimeter rubbery, mobile, and well-circumscribed breast mass. Ultrasound shows an hypoechoic oval lesion with discrete margins. What's the best management?
Observe.
During observe, during corneal biopsies.
Check back in 8 to 12 weeks.
So 1 2-centimeter mass, little rubbery jelly bean. Okay, you're gonna observe with serial imaging. When do you go to an FNA or a core?
It's over 7 or 5.
When it's bigger, when it's symptomatic. Okay, when it's not well circumscribed, when it's more matted, it's not mobile. Okay. All right, you have a 42-year-old woman presents with unilateral, suspicious, or spontaneous, non-bloody nipple discharge from a single duct. No palpable mass. What's the most likely diagnosis? No, unilateral.
Prolactinoma?
Nope. More likely going to be bilateral. If it
Give
is
me
like
an ultrasound.
galactorrhea or it's caused by something in your brain from your pituitary, it's most likely gonna be both, right? It's not just gonna affect one side or the other. So what's most likely gonna affect one side? Gonna be something within that breast, right? Not mastitis. You give up? Intraductal papilloma. Okay? Non-bloody.
This wasn't a woman's health
Okay?
test.
These are benign. What if it was bloody?
Cancer.
And what's the most likely diagnosis? Ductal carcinoma what? In situ, DCIS. Okay, good. All right, which virus category requires definitive tissue diagnosis? Four. Suspicious. All right, suspicious. We got to check that tissue. Okay. All right. A 34-year-old lactating woman presents with severe pain, fever, and fluctuant 4-centimeter periareolar mass. What's the next step? Not a mammogram. What is this? Not mastitis. You have a fluctuant mass. Breast abscess, right? What do?
Drain it.
Are you going to drain it?
Guy's gonna drain it.
Or are you going to send to a surgeon to drain?
Surgery.
Surgery, right? You're going to send to, we are going to do an IND, but we're going to be in the OR. Okay, these are normally deep. They're very, very in-depth and very painful, so we'll put them under for this. Okay, they may come to you already draining, but you should send them to the ER. Okay. What do we do for mastitis? What's the difference between a breast abscess and mastitis?
Antibiotics.
There's no mass, there's no fluctuation, right? So you'll have cellulitis, you'll have induration, you'll have warmth to the skin. Okay, we do antibiotics, and then are we breastfeeding still?
Yes.
Pumping? Yes. Do we breastfeed or pump with a breast abscess?
No.
No. Good. A 55-year-old woman with a new 2-centimeter firm irregular breast mass presents to the clinic. What's your best initial diagnostic study?
Ultrasound.
No. What type? Or mammogram, what type? Say louder for the people in the back. Oh, I heard it. Someone say it confidently. I can't tell if it's saying it. What's our 2 types of mammograms, guys? Screening, go ahead. Diagnostic. This one has a mass.
Diagnostic.
So we're going to do diagnostic, all right, all day long. Are they going to get an ultrasound too? Absolutely. But their initial test is a diagnostic mammogram. Okay, when do we do screening?
Normal.
When they
no
are
symptoms.
completely normal. That is a preventative measure only. If there's any, even if we don't feel a mass, but there's having pain, we still do diagnostic. Okay? Alright, diagnostic mammogram. Alright, you have a 65-year-old woman who has a palpable breast mass. FNA is, cytology is inconclusive. What's the next step? Ordeal. Okay. At this point, if you have a concerning palpable mass, right, you don't want to necessarily do an FNA again. Just do a core. Okay. If they wanted to do not a core, right? What's their next best step? We have 2 next steps that we can potentially do. If it's
Another
a concerning
FNA.
palpable breast mass. Excisional, which is
General
a
surgery.
lumpectomy, right? Or an excisional biopsy. Okay. Which one takes the whole mass?
The lumpectomy.
Lumpectomies take the whole mass. Okay? So if they don't want to mess around with cores, and they have like a history of breast cancer in their family, or she's BRCA1 or BRCA2, right? We're just going to go ahead and do the whole thing. Okay? All right. Which biopsy technique allows for evaluation of ER, PR, and HER2 status? What do we have to get? First, well, okay, that's a lot of murmurs. What are our biopsy strategies that we have available to us?
Excisional.
We have core, we have excisional, we have lumpectomies, we have FNAs, right? So which one? Core. At least core. We have to have tissue. Okay, if you want to evaluate ERP or HER2 and you do an FNA, you are not going to do it. You have to have tissue, some sort of tissue. Does that make sense?
Cool.
Cool. All right, a patient with invasive ductal carcinoma and clinically negative axillary nodes is scheduled for surgery. What is the axillary management, what appropriate axillary management are we going to do? Are we just going to say, oh, they're clinically negative, we don't have to do anything? No, because it could be subclinical, right? So what's our first step of evaluating our lymph nodes? Which is called what? Huh? Sentinel node biopsies. Good, right? Well, so we give them that dye, that radioactive uptake. We find that first node, we send that to pathology. If pathology is negative, what do? I think I heard it. If the first node is negative, what do? Then the rest are negative, right? If it's not in that first lymph node, it's going to be negative, right? So we don't do any more dissection. What if that first node is positive? Take them all. Good. A woman presents with potent orange skin erythema and rapid breast enlargement without a discrete mass. What diagnosis must be ruled out? Inflammatory. Good. All right, a tumor is ER negative, PR negative, and HER2 negative. What's the most accurate statement?
Bad.
Bad. All right. This is the most, it's a triple negative, aggressive behavior, worse prognosis, very hard to treat. Okay.
Cut the breast off.
Yes. All right, which mastectomy treatment spares the underlying muscle and preserves arm function? What do you think? What are our two mastectomy strategies? What are our two mastectomy strategies? Modified rad or what?
Rad. Modified
right?
rad.
So which one spares the underlying muscles?
Modified.
Modified. Good. Modified radical mastectomy. Okay? We try to keep that muscle. Alright, 72-year-old male smoker presents with an incidentally discovered 4.8 centimeter infrarenal abdominal aortic aneurysm. He's asymptomatic. What's the next best step?
Blood pressure control.
Sure. What are we going to do?
Abdominal ultrasound.
What are our strategies? What are our management strategies? Is this an immediate vascular consult? No, it's asymptomatic and less than 5.5, right? So what are we going to do?
Monitor.
Annually monitor.
Controlling hypertension.
Alright, you have a 68-year-old male presents with sudden, severe tearing, back pain, hypotension, and a new diastolic decrescendo murmur at the right sternal border. What is the most likely diagnosis?
Aortic aneurysm.
Aortic dissection. Right? Which classification is most likely to rupture? Stanford.
1.
Okay. So DeBakey's are 1, 2, 3. Right? Then you have Stanford A and B.
A.
Stanford A. Good. Alright. Which imaging modality is considered the gold standard for preoperative planning of abdominal aortic aneurysm repair? CTA what? CTA abdomen pelvis, right? Okay, 65-year-old man presents with sudden severe abdominal pain that is out of proportion to physical exam findings. Abdomen is soft with minimal tenderness. He has atrial fibrillation. What is the most likely diagnosis? Mesenteric ischemia. Good. A patient presents with a pulsatile abdominal mass and flank ecchymosis, but is non-tensive or normal tensive. What's the most likely diagnosis? Well, what is a pulsatile abdominal mass? Abdominal aneurysm. And if you have flank ecchymosis, it's leaking. Good, it's leaking. Okay? If they were hypotensive, it's most likely dissecting, versus if it's just ecchymosis with normotensive, it's just leaking. What's the treatment for that?
Blood pressure control?
Blood pressure control, and then what? A graft or TEVAR, or not TEVAR, an EVAR. Right, you gotta go in and stent that, stop the leaking. Okay. Which of the following, which there's nothing to follow, which describes a true aneurysm? What are the all layers? Tunica intima, tunica media, and tunica adventitia. I would know those 2 layers. Okay? It's not just knowing all the layers, but knowing what those layers are called. Alright, a 70-year-old male with 75% symptomatic carotid stenosis presents after a TA. What's the most appropriate management? You gotta clear the carotid artery, but how? What's that surgical term? What's that surgery name?
What is it called?
Endarterectomy. Good. Carotid endarterectomy. What if he was like a 40-year-old? Or a 50-year-old? A stent. Alright, the older they get, the more likely the stent's not going to work. But a carotid endarterectomy is always a choice. Alright. A 60-year-old male with calf pain after walking 2 blocks that resolves with rest. If pulses are diminished, ABI is 0.65. What's the diagnosis? Peripheral artery disease. Causing what? PAD, peripheral arterial disease. But what does peripheral artery disease cause that gets worse and then gets better with rest?
Ischemia?
Oh. Say it. Say it louder. I think I heard it.
Claudication?
Claudication. But intermittent claudication, right? Because it gets better. What if it doesn't get better? Then you most likely have what?
DVT.
No.
What's the DVT so bad?
Most likely it's causing critical ischemia, right? It's too much. Not going to be intermittent at that point. Alright. You have a trauma patient with a high-speed MVC that has a wide mediastinum and chest x-ray. CTA confirms injury just distal to the left subclavian artery. What's the most likely diagnosis? What caused this?
Not a broken clavicle.
Not very probable. No.
Blunt thoracic aortic.
Blunt thoracic aortic injury. Okay. Alright, it is 10:50. I have probably 50 more slides. Do you want to take a 10-minute break or just push?
You say push through?
50. 50. We're on slide 133 of 185. Break. Take 10-minute break. Any questions thus far over the material we kind of already reviewed? Is this good?
Yes.
Okay. Cool. All right. Moving on. A patient presents with sudden pain, pallor, pulselessness, and paresthesia of the left leg. Light touch sensation is absent. What's the next step? What is this? It's bad. What is the word? What is the medical word? Some sort of compartment syndrome, yeah? Maybe needs a fasciotomy?
Yes.
What's the medical term of this? You can't just call bad. So that's a cause. But what's the actual diagnosis?
It's power.
It's not compartment.
Yes, critical limb ischemia, right? And we treat it with emergent surgical interventions, most likely a fasciotomy. All right, 68-year-old patient with subclavian steal syndrome complains of dizziness when using the right arm. What's the underlying mechanism?
Subclavian artery being occluded by, what is it, the anatomy?
That's the steal syndrome. Well, that's a subclavian compression. But what does it mean when you say steal syndrome? Where are we taking that blood from? I heard vertebral artery, right? So it's retrograde vertebral artery flow, trying to overcome and compensate for that subclavian artery being blocked or compressed. Good. All right. An ABI of 0.85 indicates what? Ischemia. Maybe. Peripheral artery disease. Okay. What's the underlying pathology of PAD? If you have a 0.85, some sort of blood process. Starts with an O. Occlusion, occlusive disease, proximal to the measurement. Okay. All right, 62-year-old man presents with postprandial abdominal pain 30 minutes after eating. He's lost 20 pounds. CTA shows severe SMA stenosis. What's the first line therapy? How are we going to treat this? What is it? What is this?
Cancer.
What is that stenosis causing? Mesenteric ischemia, right? They have that food fear. They don't want to eat. They lose weight. What do we do for mesenteric ischemia? Stent. We try to stent, right? So that percutaneous transluminal angiography or angioplasty with stenting. Okay. All right. 32-year-old woman presents with a 2.5 centimeter solitary thyroid nodule. Their TSH is 0.1. What is the next best step? What do we have to know of that nodule? Hot or cold? How do we do that? Radioactive iodine scan, uptake scan, right? This is, I think, something I didn't really talk about too much. So there's two radioactive iodines. Okay, the first one is the uptake scan. It uses a low dose iodine 123. Okay, does not destroy the thyroid. Whereas the radioactive iodine that's iodine 131 in high doses, that's what we use to like ablate the thyroid. That's the destruction. Okay, so we use iodine 123 to scan, to check to see if it's hot or cold, but high doses of 131 in order to destroy that thyroid. Okay, so it kind of sounds the same, but it really, you gotta know which iodine we're using. Okay? All right, you have a 65-year-old man presents with a hard fixed thyroid nodule and ipsilateral cervical lymphadenopathy. Which feature most strongly suggests malignancy? Of his presentation,
Hypercalcemia.
hard and fixed.
Fixed.
Hard and fixed. Okay, cervical lymphadenopathy,
Oh,
could be anything. Okay. All right, which thyroid carcinoma is most commonly spreads via lymphatics? Okay, what are our two thyroid carcinomas? We have 4. But what's our two most common? Papillary, follicular. Okay, out of those two, which one spreads lymphatically? Papillary, good. Okay, think papillary, popular, lymphatics. How does follicular spread? Liver.
Lung.
Nope. No, how,
Oh,
not
how.
where, how, right? So if papillary does lymphatics, follicular does what?
Yes.
How does it spread? Yeah, blood. Blood, right? Alright, which one's more common? Papillary or follicular? Papillary. Okay, 45-year-old woman presents with hypercalcemia. Labs show a calcium of 11.8 and elevated PTH. What's the most likely diagnosis? So when you see a high calcium,
Cancer.
parathyroid, and if you have an elevated PTH, is it primary or secondary?
Primary.
Primary, right? Secondary has a high calcium but low PTH. Okay. Patient presents with kidney stones, depression, constipation, and bone pain. What lab abnormality is most likely to be expected? Hypercalcemia. Okay, what are they in? We don't know what the PTH is, but what is the diagnosis other than serum calcium being elevated? What does that lead to? Just talked about it. Yeah, hyperparathyroidism, right? But we can't decide whether it's primary or secondary because we don't have the PTH. Okay, so this is how a patient's going to present. And then you get a calcium, and then you say, oh shit, the calcium's high. I need to get a PTH. Figure out which one it is. Alright, 48-year-old woman undergoes parathyroidectomy. Post-operatively, she developed paraoral numbness, carpal spasms, especially when a BP cuff is inflated. What's the most appropriate treatment? What is she low in? Calcium. So what are we going to give her?
Calcium.
Are we going to do it oral, IV, what?
IV?
Hmm?
Maybe it's
IV.
IV.
Right? She's symptomatic. Oral takes a while and it may not absorb as well. What type of calcium do you think we're going to give her?
Gluconate.
Gluconate. IV calcium gluconate. Okay. Alright, you have a 55-year-old male presents with hypertension, episodic headaches, and diaphoresis. Men's 2 is suspected. What needs to be ruled out before thyroid surgery? Who said PO? Good. On unicorns. Right? So if you have hypertension, headaches, diaphoresis, you have to rule out a PO. Alright. 58-year-old male with follicular thyroid carcinoma presents with back pain and lytic bone lesions. Which malignancy is most commonly spread? Commanded blood to bone.
Follicular.
Follicular goes to bone. I already told you.
Short-term memory test.
Alright, 28-year-old woman presents with tachycardia, hyperplexia, and delirium and heart failure. She's known to have untreated Graves' disease. What's the diagnosis? What is she in?
Thyroid storm.
Thyroid storm. Good. Alright, a patient undergoes a total thyroidectomy for papillary carcinoma that was greater than 3 centimeters. Why is total thyroidectomy preferred over lobectomy? Why do we want to just take the whole thing? For recurrence? We can still do radioiodine therapy. Okay, and surveillance. Alright. 67-year-old smoker develops a low-grade fever and decreased breath sounds at the basis 24 hours after abdominal surgery. Chest x-ray shows basilar opacity, so it's most likely diagnosis. What do you think? What's going on in this patient? So they're post-op. Okay, they have a low-grade fever. They have abdominal surgery. Probably been sedentary in a bed. What do you think?
Mesenteric coagulopathy.
Hmm?
Something like mesenteric coagulopathy of
Nope.
some sort.
Chest x-ray shows basilar opacities. What shows basilar opacities? Bilateral basilar opacities. Atelectasis. Congratulations. Right? 24 hours after surgery. Most likely cause. It's atelectasis all day long. Right? If it's a high dose, if it's a high fever and a leukocyte, like a high leukocytosis, okay, and they have crackles, they have an infiltrate on the x-ray, that may be the first sign of like aspiration pneumonia. Okay, but less than 24 hours after surgery, most likely is atelectasis. Okay? Alright. Trauma patient, 48 hours after femur fixation, develops confusion, hypoxia, and petechiae on the chest. What's the most likely diagnosis? Fat embolus. Good. Okay, which of the single greatest factors for ventilatory associated pneumonia?
What's that be?
Duration. Good. Duration. That's the single greatest risk factor for VAP. Okay? Duration. That's why we put them on a trach as soon as possible. It decreases the oral flora from getting into the lungs. Alright, patient on heparin develops 50% drop of their platelets post-operative day 7 and has a new DVT. What's the most appropriate next step? What are they in?
Hypercoagulopathy.
DIC. Alright, they're on post-op day 7, they're probably on what? Doesn't matter what else, everything else, right? They're post-op day 7, they're still in the hospital, what are they on? Yes, but what medication are they on? Heparin or Lovenox, right? To prevent DVTs. Now she has a 50% drop of platelets. What is that? What does heparin cause?
Thrombocytopenia.
Which is what?
Low platelets.
Yes, but you have HIT, right? Heparin-induced thrombocytopenia. Okay, it's not just thrombocytopenia. It's got to be heparin-induced because she's on heparin. So what are we going to do if she's in HIT? We're stopping all heparin. But now she has a new DVT. So is that it?
No.
Do we stop there?
No.
All right, we got to fix the DVT. So a non-heparin anticoagulation. Okay? So you got to recognize HIT. All right, what is virtuous triad? What does it include?
Stasis.
Stasis, hypercoagulability, endothelial injury. Good. All right, a patient develops sudden hypotension, diffuse oozing from the IV sites after massive transfusion. The labs show a prolonged PT and PTT with a low fibrinogen. What is occurring? Say louder. This is DIC. Okay? You have prolonged PT, PTT, and a low fibrinogen. It doesn't really affect the platelets. Okay? Alright. 72-year-old is a mobilized ICU patient, develops erythema over the sacrum that does not blanch. What is the most appropriate preventative measure? First of all, what is she developing? Pressure ulcers, decubitus ulcers. Okay, what do we do to prevent it? Padding, rolling, okay, frequent turning and pressure release. Pressure relief. All right, post-operative patient develops abdominal distension, decreased urine output. They have a rising lactate and a respiratory acidosis after massive resuscitation. Their bladder pressure is 35. What's the next step? What do you suspect is happening? I don't even have to tell you what type of surgery they had, right? They have abdominal distension, decreased urine output, rising lactate, right? They've had massive resuscitation, whether it's with fluid or blood.
Happened.
With a bladder pressure 35, what's a normal bladder pressure? What do you think?
Brain say 15.
Less than 20? Less than 20 is normal? Okay? So if you have a bladder pressure of 35, what do you think is happening inside that belly?
Distension.
Yeah, but what is that distension causing?
Abdominal pressure.
Abdominal. You're so close. I can see your wheels turning. Okay, if you have massive resuscitation, okay, that's going to cause the intestines to do what? Everything swells, right?
Yeah.
Okay, so your intestines are going to be swollen. Your abdominal region is distended, okay? If you already now have decreased urine output from the swelling, okay, and a rising lactate means what? Right, greater than 4 is bowel death. Yes, abdominal compartment syndrome. This is abdominal compartment syndrome. Okay? What do we do for it? So if you have a compartment syndrome anywhere, what do?
Fasciotomy.
Fasciotomies. That is in terms of what? It's a decompression of that space, right? So if you have abdominal compression syndrome, you have to do an emergent abdominal decompression. Okay? Does that make sense?
Yes.
We most likely will see this after we've already done an XLAP. We see it a lot in burn patients as well. Okay? If they're too unstable to go back to the OR, we will decompress them bedside. Meaning we basically eviscerate them bedside. Okay? This is something we do not miss. People die from this. Alright. Postoperative patient develops more than 3 loose stools in 24 hours after receiving clindamycin with first-line treatment. First of all, what is it? C. diff. Alright? What do you want to do? Vancomycin, which type? PO. Oral. Oral vancomycin. IV vancomycin does not cross into the gut, will not treat it. May actually make it worse. Alright, post-op patient becomes confused. ABG reveals hypoxemia and respiratory alkalosis. What must be ruled out? If you have any post-op patient who is no longer breathing correctly, what's the 2 things you have to rule out in a post-op patient? Huh? Not atelectasis. PE, right? And guys, this is on every single post-op slide. What is the first thing you have to rule out on basically every complication? Your PE. Nope. Nope. What'll kill you? What will kill you if you miss it? Post-op? No.
DVT?
No. Yes, it definitely involves the heart. MI, post-op MI and a PE. Those are the 2 things that you have to rule out every single time you come across a patient in distress after operative or after we went to the OR. Okay? Especially with hypoxemia and respiratory alkalosis, we have to rule out a PE. Most likely they're going to be tachycardic. They may have a small fever. Okay? Tachycardia that cannot be proven otherwise, like we can't figure out another reason why, is number 1 cause is PE. Okay? Don't ever forget that. Anytime you have a post-op patient who becomes confused or has tachycardia or hypoxemia, respiratory alkalosis, even though you think maybe it's just atelectasis or ICU delirium, you still have to rule out a PE and an MI. Okay? Those are the 2 things that'll kill you or kill a patient, and that's a big litigation thing. So don't miss those. Alright. Patient develops a fascial wound, dehiscence with salmon-colored fluid on post-op day 5. What's the most appropriate treatment? First of all, what is it? Yes, peritoneal fluid coming up through a abdominal wound that we caused, okay? The abdominal wound, that midline incision is dehiscing, so what do we gotta do? We just leave it?
No?
No, we don't just leave it, that's good. We take it back to the OR, right? Okay, we have to do an immediate operative repair. I have to go in, open up all those sutures. Okay, the fascia is dehiscing, meaning you're very likely to like eviscerate. Okay, one wrong cough, wrong sneeze. If your fascia is already dehiscing enough that you're seeing salmon-colored fluid, you're most likely very close to coming apart completely. And so we take it back to the OR, we unzip them, we wash them out, and we do a planned delayed closure. Okay. See, that wasn't that bad. All right. What questions do you have? Any? What questions do you have?
All of them.
All of them. Okay.
Not for you.
You had to get 50.